Hi everyone, welcome to episode 4, where we talk about fertility and sarcoma with Dr. Abha Gupta, who's an expert in this topic area. Let me tell you a little bit about Dr. Gupta. She's a pediatric oncologist who has had additional specialty training in adolescent and young adult oncology. She's an associate professor in the Department of Pediatrics at the University of Toronto, and she currently works as an oncologist at 2 hospitals: the Hospital for Sick Children as part of the Solid Tumor Program, and at Princess Margaret Cancer Center as part of the Sarcoma Program. And she also is the medical director of the Adolescent and Young Adult Program at Princess Margaret Cancer Center. Her research area is in sarcomas, desmoid tumors, and adolescent and young adult oncology. Dr. Gupta is also the founding medical director of CANSARC, the Canadian Sarcoma Research and Clinical Collaboration. And that's just a brief introduction. So from that, I'm sure you can gather that she's made quite an impact and continues to in the field of sarcoma. So it's our pleasure to have Dr. Abha Gupta on the show today. She's not only someone that I admire as a sarcoma specialist and a woman leader, but also as a friend. We first met years back at a children's oncology group meeting. And whenever I see her at our conferences, she's always somebody who I want to hang out with. And you'll find out why from just listening to this conversation. She just has such a great soul, and she carries herself with confidence, and she's funny, but she has so much compassion, which I think you'll really hear when you hear our conversation with her. And I hope you love this conversation as much as Wendy and I really enjoyed having it. So let's get started. Hi, I'm Dr. Lisa Kopp.
And I'm Dr. Wendy Allen Rhodes, and we are the Sarcoma Sisters.
We are friends, moms, wine enthusiasts, and pediatric oncologists.
That means that we take care of kids, teenagers, and young adults with cancer.
We know that cancer is confusing and scary.
And our patients tell us that it's even harder to find information about sarcomas. So we are bringing the experts to you to talk about all the things.
Well, all the things important to you.
Thank you so much for listening.
All right, let's get started. Hey everyone, we have to add in this part every time for the lawyers. The content that you're listening to on the Sarcoma Sisters podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. As you all know, we have the utmost respect for your oncology medical team, and we know that they know you and what is going on with your health the best. So we want to leave all those decisions up to them. Thanks so much. All right, everyone, welcome to our podcast. So today we have Dr. Abha Gupta with us, who is a friend of Wendy and mine, and we're very happy to have her, but she's also a sarcoma specialist. But what we wanted to talk about today was fertility. So first of all, I just want to say welcome to Abha, and I do also want to mention that she is our first international guest coming to us all the way from the land of maple leaves in Canada.
That's Canada. Maple leaves.
I did say
okay.
Canada. Sorry, did you not hear it? Being from the Midwest myself, usually just have to say my maple leaves. Anyways, the reason we asked Abha, our Dr. Gupta, on to talk about fertility was because she actually is an expert in many things. One of the reasons I reached out to her, I actually had to ask her a few different topics to talk on. She is a sarcoma specialist, but she works a lot with what we call AYA, which for those of you who don't know is adolescents and young adults. And one of the topics that comes up a lot, because sarcomas happen in this age group, is fertility and fertility preservation. And depending on where you're at in the country and where you get treated, sometimes you don't learn about preserving your fertility until after treatment. So I wanted to talk about how this pertains to women and to men, and also what you can ask and how you can be an advocate for yourself and working with your team at the beginning
of treatment, or in the middle, at the end, wherever you're at.
I'm going to jump in here, Lisa, and ask Dr. Gupta a very specific question, which is, can you tell us why teenagers and young adults need to think about fertility as they start their chemotherapy and or radiation journey?
Absolutely. So first of all, thank you very much for having me join the Sarcoma Sisters podcast. I feel very honored. So maybe, Wendy, if you don't mind, I will take a step back from your question and actually pose this other question to our patients and their families. And that is, what do you consider, what is your consideration about being a parent? And the problem is that we have to ask our teenagers about their perceptions of parenthood long before they've even ever considered that. So the first question is really, do you want to be a parent? And the second question is, how important is genetic relatedness to your offspring? Now, how is it possible that a 15, 16, or 17-year-old who's just been diagnosed with cancer can contemplate those two themes in the matter of less than 24 hours, which is sometimes what's required for them to do? But it is the first thing that I actually always talk to my patients about is, please do consider and think about, do you want to be a parent in the future, number one, and number two, how important is it for you to be genetically related to your child? It's very interesting because even at such a young age, some teenagers actually are able to express the idea that, I'm okay with adoption, I'm okay with a surrogate, I'm okay with donor gametes. And maybe that's a reflection of their exposures, both online and in person. Maybe they had friends who've been adopted, or they know parents or friends of their parents who've gone through IVF. Nonetheless, I think all oncologists, I think it's very important for anybody who's actually having an onco-fertility conversation with their patients to at least start with these two themes. And the reason for that is because it actually takes away the pressure of having to actually go through a procedure to preserve gametes in this very stressful time. It just reminds patients and their parents, for whom sometimes this topic is actually much more sensitive than for the patients themselves, that we can pause, take a step back and say, look, you know what? If this isn't the right time for us to consider onco-fertility or fertility preservation, look, there's always going to be some opportunity in the future. So having said that, what was your question again?
Thank you. So my question was, so after you've had that conversation and after you've asked the patient, what they think about being a parent and how important it is for them to be genetic related to their future child, why are we asking patients that question within hours of telling them that they have a diagnosis of sarcoma?
Okay, thank you. So I will say that actually for both, I will say we will have this conversation with the assumption that there's two biological genders at this time, male and female. And the story for both of these biological genders are different. So for males, the issue is that sarcoma therapy in general consists of a high cumulative dose of a very specific class of chemotherapy drugs called alkylating agents. And the issue is that these alkylating agents halt spermatogenesis, which is the development of new sperm. Every 2 months, males generate new sperm from puberty until death. And chemotherapy actually halts that process. All chemotherapy, in fact, halts that process. However, when you have a high cumulative dose of alkylating agent, the issue is that the chance of recovery of sperm generation is not there. So for most males undergoing, we could say in general, almost all sarcoma therapy probably will never have the opportunity for generation of sperm following cancer therapy. There are parentheses to that statement, however, And that is that I always ask survivors of sarcoma, male survivors of sarcoma, to actually have a semen analysis performed in the post-pubertal stage, about 2 or 3 years following the completion of cancer therapy, because you never know. Sometimes, if there was a low cumulative dose of alkylating agent, there may be an opportunity for some sperm recovery. Furthermore, if there was a low cumulative dose of alkylating agent, some institutions actually can offer testicular biopsy in adult men, and it only takes one sperm. And so if you can harvest a sperm from testicular tissue in an adult man, you can actually technically perform in vitro fertilization or intracytoplasmic injection of that sperm. And we have had cancer survivors undergo testicular biopsy in adulthood for this reason. So therefore, for males in general, it is imperative and it behooves every single oncologist to offer the opportunity to preserve sperm for all post-pubertal boys. In fact, it is crucial that every patient and their family understand that they deserve having that conversation. Many oncologists feel hesitant. Well, maybe that's changing now, but I feel that when we were training, especially and over the last maybe 5 years ago, oncologists were hesitant to even mention the idea of preserving sperm or banking sperm prior to starting cancer therapy, because either the patient has diffusely metastatic disease and prognosis is guarded, or the patient is very sick or in pain or has an oncological emergency like spinal cord compression or a big pleural effusion and can't breathe. Or has poor finances, or the fertility clinic is far away. There are many barriers which may prevent a patient from undergoing the process of banking sperm. However, every patient and their family deserves having that conversation and the opportunity to think about it. Because we know that there's a lot of literature on decision regret and the lack of information delivery at the time of diagnosis. Because when all the waters settle, the patient will remember, nobody ever spoke to me about the option of banking sperm. If a patient is very sick, or if there are unsurmountable barriers, then of course we can say to the patient, look, I'm really sorry, this therapy is going to render you permanently sterile, but it is just not feasible at this time for you to bank your sperm. Obviously, the opportunity for sperm banking is not available for those who are pre-pubertal. And so for boys who are not yet through puberty and have not masturbated or ejaculated, that opportunity does not exist. Some institutions do offer pre-pubertal testicular biopsy, which still remains an experimental procedure. So for males, the story is clear-cut. Just to summarize, with a total cumulative dose of alkylating agent, we can be somewhat concrete in our advice to males that they will likely be sterile or not have the opportunity to have sperm regeneration following cancer therapy. For girls, however, it's much more complicated, or for females, it's much more complicated. Females are born with a set number of oocytes at birth, and nature has it that every year, the number of oocytes in a female's ovaries will slowly decrease until a certain plateau is reached, upon which menopause will be achieved, or lack of ovarian function is achieved. Chemotherapy exposure simply accelerates that natural loss of oocytes. And so imagine if a girl is age 15 at the time of exposure, she still has a lot of oocyte reserve left in her ovaries, and therefore, even if her oocyte decline is accelerated with the exposure to chemotherapy, by the time she's 18 or 19, she should theoretically still have the opportunity to harvest eggs, when she's a young adult. If, however, a woman is in her early 30s and she's exposed to the same chemotherapy, because her baseline reserve is already so much more limited than the 15-year-olds, it is likely that following chemotherapy, the chance of actually harvesting oocytes is probably much, much more limited. And there is a risk of permanent ovarian failure with exposure to chemotherapy in someone who's in their mid-30s. So there are studies that have been done in survivors of childhood cancer that clearly state that women or females who've been exposed to chemotherapy alone probably have the same opportunity for natural pregnancy as their normal siblings or the normal population. Of course, we know that 15% of couples experience infertility, and so we never know what an individual's baseline fertility is prior to cancer therapy. And unless a girl's or a female's ovarian reserve is actually assessed prior to chemotherapy, just based on her age alone, an oncologist cannot guarantee that she will have enough ovarian reserve following chemotherapy, to want to harvest eggs if she wants to. So there are multiple pressures, I think, that are expressed by varying teams about the need for egg cryopreservation in teenage girls prior to starting cancer therapy. And this, to me, this is actually quite controversial, because I think asking a sexually inactive teenager to actually undergo egg cryopreservation is a big ask. The harvest procedure itself is very different than sperm banking for males. It involves transvaginal ultrasound, transvaginal procedures that are usually done under conscious sedation, not even under general anesthetic in many places. And again, it can be quite an invasive consideration for someone who is not yet sexually active. And even for those who are sexually active, also, it is an uncomfortable procedure. Moreover, the procedures, if not covered by your insurance, are very expensive, as is the yearly annual storage fee of these gametes. If a female, or male for that matter, is going to be exposed to radiation for their sarcoma that involves the pelvis and both ovaries, then the stakes are much higher, and then we can be much more concrete in telling a female that most likely your sarcoma therapy will render you with complete ovarian failure because of the radiation therapy. But in the absence of radiation, I think it's a much more cautious and detailed conversation to have with the patient. Maybe I'll pause there.
Thanks, Abha. Yeah, I was going to have you back up just to answer a few questions. First of all, thank you so much. That was an amazing summary for both the men and the women. I know for some of our listeners, a lot of these terms, which I know when you're talking to a patient, I'm sure you spend much more time breaking it down. So I was going to have you break it down a little bit. But first of all, just to summarize, so if a woman is getting, or a young woman is going to have chemotherapy, then we don't really know the percentage that they won't be infertile or have ovarian failure. But if they're going to get chemo and radiation, then there's a much higher chance that they'll either go through ovarian failure or have ovarian failure or not be able to collect their eggs at a later time.
It depends on the field of radiation. So if the patient has a sarcoma in their shoulder, then there's no impact on their extra impact on their fertility. It's only if the field of radiation encompasses their pelvis. And sometimes actually patients have sarcomas in their proximal thigh, and that's actually a tricky place too, because it's not necessarily technically pelvis, but sometimes the radiation field does have exposure to their pelvis and can compromise ovarian function. However, women fortunately have 2 ovaries. So there is no compromise of fertility in someone with a single ovary. And we know that from the germ cell tumor literature, women who have single ovaries have a normal likelihood of pregnancy. So if only one ovary is affected by radiation and there's no scatter of radiation therapy to the other ovary, then technically the patient should still be, that ovarian reserve of the unaffected ovary should still be intact. But this is where it becomes very challenging for sure to have these detailed conversations.
And maybe I should have backed up to say, what do you mean by ovarian reserve?
So imagine a balloon filled with lots of marbles. And at birth, that balloon is packed filled with marbles, and each marble represents an egg. every year you take a marble out, that's it's really depressing actually, but that's really what an ovary goes through every year. Actually, every time I give this talk and show the picture of the ovary, especially before when I was like, in my 30s, I was so depressed thinking of like how
You were
the
losing your
ovary
marbles.
declines. I'm losing my marbles. And so chemotherapy accelerates the number of marbles that are missing from that balloon. So if you don't have enough eggs or marbles in that balloon, it will be much more difficult to naturally conceive a baby.
Thanks. That's such a great explanation. Oh, go ahead.
We always
Wendy.
do this. So I had a couple of follow-up questions. Well, a statement and a follow-up question. Number one, I think this is a good time to point out to our families that if they are going for a radiation consult, because none of us on this call actually give radiation, we send everyone to a radiation oncologist. These questions about the risk to the ovaries due to radiation is a conversation to have with both the oncologist and the radiation oncologist, because they can give more specific details about what dose the ovaries are going to get. And then the other question, or what I wanted Dr. Gupta to speak a little bit more about, is I'm sure some of our listeners have heard about moving the ovaries around during radiation. So can you tell us what that's called and what that means?
Definitely. So the name of moving an ovary is called oophorecpexy. I don't even know how to say it, but the idea is pexy. So the idea is to actually physically take the ovary from its spot, which is low in the pelvis, and move it anywhere really outside of the field of where radiation can be. It's kind of magical that you can even do that and that the ovary still survives, but it is very cool that you can actually physically, it's a surgical procedure under general anesthetic, and a gynecologist will actually take that little ovary or take that little balloon and move it up, maybe sometimes under the armpit or just far away from where the radiation exposure is. And it's not 100% guarantee, but it definitely is an opportunity to save that ovary from exposure to the highest field of radiation. This procedure is actually also very relevant in prepubertal girls or prepubertal females who obviously are not ovulate. Well, I haven't actually said this specifically. The opportunity of harvesting eggs is only available for those who are post-pubertal, because you need to have actually eggs that are ovulating. And so for prepubertal girls, the only opportunity might be to actually move that ovary out of the way. Actually, we didn't talk about ovarian tissue. I don't know if you want me to talk about ovarian tissue harvesting. There are some centers which offer an additional procedure called ovarian tissue harvesting. Ovarian tissue harvesting implies that you're actually cutting a piece of the ovary itself. So it's a surgical procedure under general anesthetic where a surgeon would actually remove part of the ovary and put it in a freezer. Now, in adult women who have mature eggs in their ovary, some centers, especially in Europe, can actually harvest eggs from that ovarian tissue from a post-pubertal female and freeze that and collect that egg from the ovarian tissue to use for in vitro fertilization or IVF. If the tissue comes from a prepubertal female, however, there are no mature eggs there. There are only baby eggs or immature oocytes. You cannot make a baby from a baby egg or an immature oocyte. And so what usually happens is that tissue, that ovarian tissue, is just put in a freezer with the possibility of two things. One is that maybe technology will move forward in the future to be able to actually take those baby eggs or immature oocytes and make them mature in the petri dish, in vitro maturation, which scientists are working on. And the second possibility is that that ovarian tissue would be reimplanted back into the patient in the future. Now, I have 14 exclamation marks after that statement, because in anyone who has cancer, there is significant risk of reimplantation of ovarian tissue. However, this is a very, very important procedure in those patients who have benign disease, who undergo sterilizing treatments like bone marrow transplant, for example. And in that population, reimplantation of ovarian tissue is definitely a very viable option of restoring ovarian function and fertility. But there are definitely huge concerns and cautions that should be observed in in reimplantation of ovarian tissue in cancer patients. My policy is that it's contraindicated in every diagnosis. It's controversial. Another thing before I forget, Wendy, you had made a comment about speaking to the radiation oncologist about ovarian exposure. Actually, that's very important for males as well. The testicular tissue is very, very sensitive to radiation, actually even more sensitive to radiation than the ovary. And so even for males, when they're meeting with their radiation oncologist, if they have a proximal thigh tumor or an abdominal tumor, the question is, what is going to be the exposure of the testes to the radiation? So it's an important question for both males and females.
Yeah. The other thing I wanted to mention, which actually just came up recently for me, in the context of specifically for radiation and getting damage to the ovaries, sometimes it's not always just about fertility preservation, but our ovaries are important for many things, including bone health, and some other things you can probably talk to.
Mm-hmm. Yeah, excellent point. 100% actually. Very, very important. This idea of kind of maintaining an estrogen state is crucial for sure. And, I don't know whether you would want that even to be a completely separate topic in terms of sexual health, but I think that to what you just said, yes, consideration of oophoporexia for preserving hormonal state is very, very, very relevant. I will say, fortunately, however, since sarcomas are not estrogen sensitive cancers, for females who do undergo ovarian failure because of radiation, there is an opportunity at least for having hormone replacement therapy, which is totally safe. You're not going to stimulate the sarcoma.
Dr. Gupta, when we were talking about this, talking about the patients and about the women and the men and about these people being young adults and sometimes very young, 13, 14, 15. And so exactly to your point, how are they supposed to know if they want to have a child later on in life? And some of these teenagers, of course, have very strong opinions, and some of them do know. And I respect that they might not change their mind later in life, and I think it was so important what you said about asking them, is it important that your child is genetically related to you? The other thing that came to my mind, though, as soon as you brought that up, was that a lot of times parents have very different opinions than their children. And have you run into that before, where the teenager says, I don't really want to go through a procedure, and I'm okay with maybe adopting a child later on in life if I can't have children, but the parents are like, no, you're going to change your mind. And how does that go? What's your experience with that?
For sure. That happens all the time. I mean, with every aspect of the cancer treatment, actually.
That's so true.
As a tangent, in terms of what type of operation to have for limb salvage surgery for osteosarcoma, all the time. Here we offer something called rotationplasty often, and the parents are like, hell no. Can I say hell? Heck no. And
it's not explicit in Canada.
Yeah, it's true. We're really liberal up here. So yeah, there's always discordance not always, sorry, there is often discordance between parental and patient perceptions and desires, and rightfully so, actually. And so it's really important to just, make sure that there's time, right? How do you expect a family to make this decision in a day? And I think as oncologists, sometimes we have to take a step back and ask ourselves, look, is it really going to make or break the situation here if we postpone starting cancer therapy by another 2 days? Probably not. And so I think it's okay sometimes if there is discordance and further discussion required, to give the family some time to talk it out. At the end of the day, though, the person who's going to undergo the procedure, whether it's even sperm banking, we've had young men say, no, I'm not interested in banking my sperm. And the parents are like, no, Johnny, you better go wank off and bank your sperm right now. And I'll be standing outside the room waiting until you do it. And so, the patient has to consent to the procedure, not the parent. So in the US, I understand that the age of consent is 18. Is that in every state?
Yes, but we do have something called assent too, that if the patient is at an age where they're capable of making a decision and understanding, then you should be getting their opinion too.
So actually here, there is no age of consent. And so if the patient is technically able to give consent, they have to sign for the procedure. Well, they may not have to physically sign, but they have to consent to the procedure, not just assent. So they can't, of course, there's going to be some element of coercion possibly involved still, but there has to be, it's actually the oncologist's responsibility to ensure that the patient's views are being well represented and not the parents' views. And so I think as long as, there's time for open dialogue and the patient understands that he or she has to be the one giving consent. And more finally, the family has to understand that it's actually the patient who's the only one who's going to be eligible to use the gametes at the end of the day, I think are important things. There was actually a student that I worked with who also did a study or wrote a paper about the idea of the use of the gametes in the future. Because imagine that a parent has paid for 15 years of storage, and then the young adult feels this guilt or obligation to actually use those stored gametes because his or her parent has actually paid for their preservation for all this time. It's actually quite fascinating when you think about the implications of freezing gametes in minors, in people who are 15, and whether or not they're actually going to be able to use them in the future.
That's, I never really thought about the kind of pressure aspect of using the gametes in the future. I've thought about the legal and ethical implications, but not kind of the pressure on the patient. One thing I wanted to just go back a little bit more to is what you said, that about 2 days not making or breaking the situation to kind of make some of these decisions regarding fertility and fertility preservation. And I think, this came up in our first conversation, Lisa, with the Maters, is that sarcomas are different than a lot of other childhood cancers. And so somebody at the beginning of a childhood cancer diagnosis, a lot of people, once you find out that there's a cancer diagnosis, no matter what it is, feel this pressure to start. And then if you start looking into the childhood cancer literature, you see things like leukemia, lymphoma, where there is a very rapid start time to it. But talk to us about what a normal start time and what a reasonable start time is if people need to have a little bit more time to make these decisions, specifically for sarcomas, because we all think that we're the special snowflake of oncology. So we want to talk about how it's different than other things.
Yeah, I think it's a really important topic. I remind families actually that the sarcoma's probably been there for minimum 3 months, right? Sarcomas don't emerge overnight, whether it's osteosarcoma, Ewing's, rhabdo, anything. These things, maybe rhabdo or other soft tissue sarcomas grow a little bit faster, but especially bone tumors, they've been there for a long time before we get that path report to say this is cancer. And so I think for many reasons, it's important to remind a family that everybody can make a very careful treatment plan here rather than a rushed treatment plan. And that includes confirmation of the diagnosis, of the staging, getting all the pieces in place before embarking on cancer therapy. And that includes onco-fertility and making sure that everybody is comfortable with the situation. There is actually literature. There's a paper published in Ewing sarcoma that confirms that a delayed diagnosis does not impact survival. And this is crucial. And I quote this paper all the time, especially for families with Ewing sarcoma. because there is so much guilt for a parent to say that I missed this. And Johnny was complaining of their sore knee for 6 months. I thought it was just from soccer or hockey. And it's okay, because even I'm sure both of you have said this to your patients as well. Even if you would come here 3 months ago, everything would be exactly the same. A sarcoma will not metastasize in the 7 days it takes for us to preserve fertility. It just doesn't work that way. And if it does, then, the cat's out of the bag anyways. It wouldn't have, this just speaks to the biology of the disease. So, but in terms of the time required to preserve fertility, this depends on where you live and where is the closest fertility center. To bank sperm, the procedure is non-invasive. You have to have a fertility clinic, or actually sometimes if the fertility clinic allows, you can actually, have the teenager collect their sperm in the hospital, and then we have families keep the container under their armpit and run down the street and to the fertility clinic and drop the sperm off. And so usually, the things that can delay sperm collection, though, is pain. If someone's in a lot of pain and they can't have an erection or masturbate effectively, it can be quite distressing. And so sometimes we do in those situations give kids a couple days of opportunity to try if it's important to them. It can be very devastating emotionally for a young man to feel like they can't actually ejaculate effectively. And so it's actually very important not to induce a sense of failure if a person cannot actually ejaculate, the first time. For women or for females, of course, the process of preserving eggs is invasive and takes time because you need to administer drugs for ovarian stimulation. And however, fertility clinics now, especially the ones that are liaised with oncology centers, have what's called random start protocols. And so they're cycle independent. And so you don't need to be at a very specific date within your menstrual cycle in order to actually start these drugs to stimulate ovarian, to stimulate egg development. So, fortunately, we have a fertility clinic that's very sensitive to cancer patients. And so for us in our city, from the date of referral, usually the harvest can take place within 2 weeks. But it's pretty tough to, have the conversation, have the consent done, and then make sure that the teenage girl is ready to undergo this procedure. And that's short of a time frame. I mean, most adult mature women take months to be able to make these decisions that we're asking our teenagers to make very quickly.
Dr. Gupta, one question that I had, which I should have just Googled and looked up, but you're practicing in Canada. What did you call it? The land of maple leaves, Lisa? And you obviously have a different healthcare system than we have in the United States. And in the United States, the coverage of fertility preservation is dictated state by state. So I think the last count I saw was 9 states had coverage, and I might be off on that. And so I am in a state where we don't have fertility preservation coverage. So it can get tricky. What does that situation look like for you in Canada?
It's very difficult for sure. So also it varies province to province. In Ontario, where I am, there is coverage for freezing. There is partial coverage for having eggs collected prior to cancer therapy, but not following cancer therapy. So remember that scenario I gave at the very beginning that the 15-year-old says, okay, I'm not going to do it now, I'm going to do it when I'm 20. Then there's no coverage. There's only coverage prior to cancer therapy. It makes no sense. It's complete garbage, but that's just the way the politicians have decided. And if parents have private drug coverage, sometimes it can offset the cost of the drugs, which are also very expensive. But my understanding is that in the US, the private insurance coverage for all fertility procedures is far better than our public coverage here, and parents would have to have very good private coverage also to help offset the cost. But in general, it's pretty expensive.
Yeah. For some reason, I thought it was better up north. But I think,
not for
Interesting.
fertility.
A lot of our private insurances, and this is a conversation to have with a financial counselor or a representative at the insurance company, but a lot of our private insurance companies have good infertility coverage, but that means that it doesn't cover it before. So it's the flip, right? Like you don't have infertility until you get your cancer therapy. And then the definition of infertility often centers around, trying to get pregnant for X amount of months, which again is complete garbage because we don't necessarily want our 18-year-old to, try to get pregnant before they're ready. So there are those kind of nuances. And I don't know, for me as an oncologist, it's one of the most frustrating conversations I have to have because it is very heartbreaking. And a lot of our families have to make a decision based on finances instead of the data and where their heart is, where their ethics are, where they believe that their life is going to go. And that's very devastating to watch. So, I mean, hopefully that's
for sure. Yeah, for sure.
Yeah, another issue that we would see, or I've seen in the multiple areas of the country I've worked, is that many of our patients don't have private insurance, so they're on Medicaid, and then it's even less coverage. So I know, and we can put a list of resources in our show notes for places like Fertile Hope, because there are places that will help to cover. But another point that you had brought up, Dr. Gupta, was talking about the yearly cost of storing, because it's not just the procedure itself, but then you're also paying to store every year that egg or that sperm, and of course that's gets expensive too.
I think the other actually aspect of this is that it costs to use the gametes in the future. Right?
Yes.
So let's suppose you've frozen sperm, but you're, maybe you would have an opportunity for intrauterine insemination using that sperm, but if not, to have to pay then for ICSI and IVF using either with the sperm is expensive. And of course, if you have eggs, you have no choice. You have to do ICSI and IVF, which is also a very, very expensive thing. And by that time, you will not be covered by your parents' insurance. So for a young adult cancer survivor to have a job with which they have excellent private insurance, I think is probably also a challenge. So
I see that we're getting close to the end of our time, but I wanted, we're talking about all the challenges from moving the ovary around to difficulties achieving sperm banking and now insurance costs. But I wanted to loop back around to what you said in the beginning, Dr. Gupta, that even though there are multiple challenges to getting this done, I think the data clearly shows us that our patients, when they are survivors, still are clearly articulating to us, even if nothing could have been done, even if there was 700 barriers in place, I still wanted to hear and I still wanted to have this conversation. Is that an accurate representation of the data?
100%. In fact, the most important thing that I always talk to fellows about when I'm speaking about this is we can make no assumptions. That's the bottom line. Make no assumptions. We are not the stewards of deciding who gets the information. Just like we routinely talk about nausea and hair loss with chemotherapy, fertility and sexual health should be part of that conversation. And that's actually what we need to train this generation of physicians to do, as well as every other. 100%. Thank you for affirming that.
Lisa, I cut you off there. You had another question, I think.
So one other question I had was for when patients are in survivorship, because we know that people will be listening to this podcast at different parts in their sarcoma journey. So what advice can we give them if maybe they were at some place where they didn't talk about this in the beginning, or they've changed their mind? What's the best route for them to start with?
So, one of the most difficult emotions for anybody to live with is regret. And there's a lot of literature actually on regret, decisional regret, especially in women with breast cancer just because the population is so large, for those women who were either not given an opportunity to freeze their eggs or declined freezing their eggs. They were actually given the opportunity, declined, and now regret that decision. So for anybody who is expressing regret with regards to fertility, I think, or anything else actually, the most important thing is to give them time and space. And so they need to have a professional with whom they can talk to. Can't turn back the clock, and everybody knows that, but there is, I think, a huge advantage, and this is just from my personal experience. I don't have literature to back this up, but there is a huge benefit, I think, of ensuring that in survivorship, people have professionals with whom they can share their grief with. It's sharing loss, the loss of their ability to have a biologically related child. And so that's a very, very powerful emotion. I think that a lot of people experience, even who haven't undergone cancer. So having someone to speak to about that, I think, is important. Secondly, I think as the survivor in the survivorship clinic, helping the patient navigate other opportunities, either through referral to a fertility clinic where they can get possibly a donor egg or donor sperm, I think would be also part of a survivorship care plan, which is relevant. So it's definitely something that needs to be discussed in survivorship.
Thanks. I think that is so powerful what you said, especially about regret and about giving people the space to sit in that, but with a professional who they can talk to, a therapist who they can have trust in and talk to. That's so important. And also the point that it's never that you don't have other options. There are other options, just sometimes you don't know them, so you can't see them,
Correct.
So thanks.
Absolutely.
I think we could talk for like 4 hours if we had the time.
I know. I wish we could just go on and on and on.
Yeah, this has been really, really helpful. And I think, I'm watching the time because I know we all have calls and stuff, but I'm thinking back and thinking to the conversations that I've had and the conversations I've seen happen. And I think even just this hour-long discussion is probably a lot more time than some people have gotten to just dedicate to this topic. And so it's definitely not completely comprehensive. There's a lot of nuances buried in this conversation, but I hope that it brings up the topic for discussion with people's oncologists, their radiation oncologists, their survivorship doctors, maybe referrals are made to REI specialists, et cetera, et cetera. Like you said, there are always options, and this is really just scratching the surface. But I really want to thank you, Dr. Gupta, for joining us on our second podcast. And, we'll probably reach out to you again in the future for other topics, and maybe we'll be a little more polished at that time, and I won't be in a loud hotel lobby. So thank you so much. I really appreciate it.
Thank you so much for your time.
Good luck with the house, Wendy. Nice to see you, Lisa.
Thanks for listening. Follow us on Facebook, Instagram, and Twitter, or find us at sarcomasisters.com and drop us a note. If you enjoyed our podcast, please share with a friend. Thanks so much. Till next time.